to the new episode of the JCMC interview series. As always, I am Michele Introna, neuroanesthesiologist at Istituto Best of Milano, and today I'm very pleased to be with Ilonka de Kejizer, who works in UMCG Groningen in the Netherlands. And she will talk about a nice paper that we published in the JCMC, which is impact of clinicians' behavior and educational intervention with mandated blood pressure and the hypotension prediction index software on intraoperative hypotension, a mixed methods study. So welcome, Ilonka.
Thank you so much for this introduction.
So I would start briefly with a short explanation on what's your study is about.
Well, short might be difficult since it's a mixed method study. What we aim to do is not only assess behavioral aspects of the intraoperative management of hypotension, but also assess whether the implementation of the hypotension prediction index would improve clinical outcomes in the sense that hypotension would be reduced. And we would compare that to an educational intervention with a mandated mean arterial pressure and to standard care. So that's in short what we did. And how we performed that was by performing first interviews with clinicians to assess what barriers were in the management of intraoperative hypotension. And based on those interviews, they developed a questionnaire. And those questionnaires were distributed across our departments to assess if the general population of our department agreed with what came out of those interviews. And those questionnaires actually told us that there were a few barriers in the management of intraoperative hypotension. And the first was actually that it's just difficult in some situations. In case of trauma, in case of major blood loss, in patients with difficult comorbidities, cardiovascular or renal comorbidities. And a second part was that you never can have the same plan for every patient. So you have to keep adjusting for every different patient. And the third barrier was that although it is primarily the responsibility of the anesthesiologist, of course, and anesthetic team, to manage intraoperative hypotension, that it is also appreciated if it's like a carried responsibility for the entire team, also the surgical department. And those three things actually made it difficult for clinicians to manage hypotension. And that was the behavioral part of the study. And the clinical part of the study, as I briefly stated, was about 3 cohorts. First, we assessed the incidence and time-weighted average, which is a measure of severity and duration of hypotension in a standard care cohort in 50 patients. And then we gave the clinicians an educational intervention, which consisted of a refresher actually on the known association between intraoperative hypotension and adverse postoperative outcomes. And we asked them to keep the mean arterial pressure above 65 throughout the entire procedure. And in the third cohort, we implemented the hypotension prediction index. The clinicians were able to use it, and not only the HPI, but also the secondary variables it provides, like stroke volume variation and DPDT, for instance. And what we found is that actually between standard care and the educational intervention, there was no difference in time-weighted average of hypotension. But when the HPI was used, we did find a difference regarding the time-weighted average of hypotension. And the final part of the study consisted of a questionnaire, which was only provided to the clinicians that used the HPI. And they generally reported that they found it beneficial. They were happy to use it, but they weren't sure if it would improve outcomes. And this was also quite at the beginning of the HPI. So literature regarding HPI and outcomes were not available yet. So yeah, it was consistent with the literature that no improvement was found yet, but that's in short what we did in our study.
So because your data set refers to what year? When did you start the enrollment?
We started in 2019 and we finished up in 2021. Yeah.
Okay, so just for the listeners and to keep track of the pathway, I would like you to ask what was the journey from the generation of the idea and to the data collecting and to the writing of the paper.
Well, I think about 10 to 15 years ago, the big papers came out regarding intraoperative hypotension and adverse outcomes postoperatively. And I only joined this research group a little later in 2019. But my hemodynamic research group was already really focused on things like this. And they were approached by Edwards to perform the validation study, a retrospective validation study. So they collected data and that was the external validation of the hypertension prediction index. And after an external retrospective validation, it's of course good to also do a prospective validation. But with all big new things, you're not alone testing this and wanting to research this. So the team was very eager to not only assess the clinical part, but also to assess a more behavioral aspect, because clinician behavior is actually really important in adopting technology, but also in detecting why intraoperative management of hypotension remains so difficult, although we all know that the association with adverse outcomes is there. So that's when also the technical, not only the clinical part was thought of, but also the behavioral parts. And I think what was really important is that they, at the time, they did not only wanted to do proper hemodynamic management by preventing intraoperative hypotension, but they also wanted to try to prevent it with the right treatment. So they made a very extensive algorithm, as you can see in the paper. And with that algorithm, we try to make sure that intraoperative hypotension was treated causally. So vasopressors were used at the right time, fluids were used at the right time, and inotropic agents were used at the right time. So that's kind of the pathway from the idea to the start of the study. And during the study, it was conducted in the UMCG where I work and in York Hospital to have two different populations, but also a two-center study. And after we finished up, we collaborated with Simon Davies, who is the PI of the study, to finish it up with the paper that was recently published.
What is really fascinating to hear, and I know what you're talking about because I was there, I've been in UMCG. It's that, and it's nice to hear from scientists that research is a team effort. It's not just you are talking about us, you are talking about the team, and this is the only way for producing high quality data sets and high quality science. So it's a message that we always have to keep in mind that organization, logistics, and team efforts and team roles are the key for research. And regarding the practical aspects of doing research, if you could just tell us in brief what were also the challenges in performing the studies.
Well, you're very correct. Without the team, it wouldn't have been possible. And it's always surprising to see how many people are involved in performing a clinical study. So I'm really grateful for the entire team that worked with me on this project. But one of the challenges in a practical sense is that we started in 2019 and finished the study in 2021. And that was, of course, COVID, because I was a full-time research PhD candidate at the time. And just from one day to to the next day, I couldn't come into the hospital. We had to abruptly stop our research. We weren't really sure when we could proceed. And of course, all the attention wasn't focused at research, but just at managing healthcare during the pandemic. So I think that was kind of the practical challenge we faced. And I think in a later stage, a challenge for us was to write a mixed method manuscript in which we could address both the behavioral part properly and also the clinical part within a word limit. So I think that was the biggest challenge of finishing up the study.
Okay, perfect. Thanks. I was also curious because you know that many criticisms came out in the past months regarding HPI. So there is a lot of discussion at the highest levels of scientific community in intensive care and anesthesiology. So I would like you to tell us if you think that all these criticisms that were raised could influence the interpretation of the data, because this data set is referring to data that were collected in 2020, so where there was not such a discussion in the community. So I was wondering if this could have been impacted your data.
I think it's definitely relevant. I do not think it necessarily affects the results of our study because it didn't impact us at the time, but and it would have been difficult to address it if it was happening while we were conducting the study, I think. But I think it's definitely true what you're saying. There's a lot of criticism, and it's especially regarding the predictive abilities. Linear extrapolated mean arterial pressure has been suggested as mean arterial pressure itself as a predictor of hypotension. And the difficult part is there are a lot of suggestions in the literature, but a direct head-to-head comparison between HPI, mean arterial pressure, or linear extrapolated pressure is not there yet. So we're still kind of waiting on those results. And I think what is kind of overlooked in this discussion is what I also mentioned earlier. The HPI also delivers secondary variables, suggesting things about contractility, pressure responsiveness to fluids, and fluid responsiveness. And I think currently we're only focusing on the first part. So we're primarily focusing on the prediction of hypotension. And I think more research is needed to assess whether those other methods are comparable or not. But I think the second part, which is actually the holy grail in hemodynamics, of course, assessing what the causes of the hypotension, I think that's equally or even maybe more important. And I think we're kind of overlooking that at the moment. So I think that needs to be addressed as well, but maybe in a later stage. And what we found is in our second cohort, we asked clinicians to keep the mean arterial pressure above a certain threshold, and it didn't improve outcomes. So that suggests we do need an extra alarming function to help us with that. So I wonder if mean arterial pressure, for example, is equal to HPI, will it perform clinically just as good as HPI? So I think we need a lot of more research to answer a lot of those questions. And it remains a very difficult topic because also if you're trying to assess predictive abilities, you need a cutoff threshold, just like the HPI has 85. We need it as well for mean arterial pressure or linear extrapolated mean arterial pressure as well. So there are a lot of answers or a lot of questions that still need to be answered regarding this topic.
Perfect. Very, very clear as always. So partly you already answered, because I would have liked to ask you where we can build on from this trial, from your study, but I think you partially gave us an answer, but I would like to be more clinical and asking you, how do you feel the outcomes of the study should impact the practice of the average anesthesiologist today, reading the paper or listening to this podcast?
Well, I think primarily we need to be aware of our barriers. And I think this paper illustrates a few of the barriers that people feel towards managing hypotension. We also need to be aware that in the second cohort, we didn't see an improvement regarding intraoperative hypotension, suggesting that this method probably doesn't work. So if you don't have the availability of HPI or anything else in your hospital, it's better probably to set an alarm a little higher than a mean arterial pressure of 65, because when it reaches 65 or below 65, you're a little bit too late. So in that sense, I think this paper illustrates that a proactive approach is necessary, and that although you might not have all the resources, please try to think about what could cause hypotension and treat it causally instead of always using fluids or vasopressors or giving a standard approach for every patient. So I think that's kind of what we can address clinically. And of course, for the future, I kind of answered it, but I think there's a lot of things we can look at. But primarily, I think a proactive approach is really necessary, and preferably a causal treatment for hypotension rather than giving a solution by treating it differently with vasopressors or fluids or inotropes when it might be something else that's causing hypertension.
My suggestion would be to follow all the discussion that is happening on the topic, because it's it's very important clinically, first of all. And the discussion regarding HPI in this moment is really something you have to keep an eye on, even if you are not into hemodynamics. It's really a really hot topic, and this is why I'm so proud that the JCMC publishes such papers, and also invest efforts in spreading science through this podcast and video series. So I think we are we are reaching up an end. So because the time is running out. So thank you, Ilonka.
Thank you so much for having me.
And for the listeners, I invite you all to subscribe our channels on YouTube, Spotify, Amazon Music, Google Podcasts, and all the podcasting platforms. And see you in the next episode of the JCMC interview series.